those of you who attended Complanet and attended the Yoki's talk in the morning, you are really, warriors. I appreciate you being here. It's my pleasure to welcome Dr. Daniela Paolotti to the Network Science Institute. Daniela got her PhD in physics, and then she was a research leader of computational epidemiology and public health. This is what she is now. She is a computational epidemiology research leader and the leader of public health group at ISI Foundation in Turin. I know she has beautiful pictures of it. She works on the influenza net system that you may have heard of or you work on. And that was a predecessor to, you may have heard of the Flu Near You. They came after the influenza net. And Flu Near You is an American thing versus the influenza net is run in Europe. Ten countries. So thank you very much for being here, and we're looking forward to your talk.
Thank you so much, Tina, for this kind introduction. Thank you for amazing hospitality. Thank you all for being here. I know that after a very long week of talks and presentations, yet another one might be too much. I hope to not bother you too much with what we're going to talk today. So, and also let me also thank the people, the Network Science Institute, Alex, Sam, and everybody who is granting and having a good time here in Boston. So, digital traces, what are those? I would like to convince you how you can use what we call digital traces, that is, the traces that humans leave around when they interact with the web, with the internet in general, to try and forecast diseases and with a focus on flu. But before delving into that, I would like to tell you a bit more about my institution. I am a research leader in the now computational and digital epidemiology group at ISI Foundation. ISI Foundation is a private research institute with 30 years of history. We are about 40-50 researchers. It's based in Turin, in the northwest of Italy, close to Milan. And we focus on data science, network science, and as you will see, computational and digital epidemiology. And we are mainly supported by EU projects, European Union, European Commission projects, bank foundation, but also industrial partnerships with banks and industries in Italy. Our research activities span a broad, let's say, set of subjects that go from very foundational themes related to mathematics of complex systems, of which we have one of the people who are involved with, Giovanni Petri, who is in the audience, throughout a more applied approach that involves complex systems in general, data science, with a very strong focus on computational and digital epidemiology. And this is the group in which I work, and it is basically the focus of our group is to apply data science on health-related issues with a strong, let's say, attention to the social aspect. So we don't want only to detect a disease and count how many people got vaccinated for flu, but we also are interested in knowing more about behavior, attitude, and all the social aspects that can have an impact on the health of individuals. For this, we use all the tools that come from data science, so complex systems, machine learning, network science, applied to health, to have perspective on population, say, issues, more epidemiological aspects, infectious diseases, but not only, even non-communicable diseases. And in particular, at ISI, we focus also on epidemic forecasts, web-based surveillance, brain science, and high-resolution contact networks. Today, I will focus mostly on epidemic forecasts and web-based surveillance, and I will show you how web-based surveillance, in all its aspects, can be used exactly to carry out epidemic forecasts. When it comes to diseases, the picture that public health officials usually get is like this. So the actual burden of disease affecting the health of the entire population is mainly hidden by the official surveillance carried out by the sentinel doctors in a specific country. And usually surveillance only sees this fraction of information related to visits carried out by general practitioners, more severe cases of a disease related to hospitalizations, and even fatal cases when it comes to counting casualties. What's going on actually in the general population usually remains a bit of an uncertainty. Imagine if you are a healthy adult, you get the flu or you get what we call influenza-like illness. Usually 90% of healthy adults don't go visit a doctor. Myself, in the first place, I just stay in bed, I play around with my phone, and that's why when it's really the time to understand what's going on among the general population in terms of health, in the past decade, the attention of the scientists has been turned to the so-called big data. So the idea is that you can use digital data, that is the data generated by the interaction of individuals with, for example, social media, but even other platforms like Wikipedia or any kind of digital platform can be used to carry out the so-called digital disease detection. So really having a very accurate idea of what is the activity of a certain disease, in the specific case we will focus on flu, circulating among the general population. Already in 2011 there have been several pioneering work by Professor Paul Green, which used among the first Twitter as a way to count how many people got the flu by as a proxy counting how many times symptoms or keywords related to symptoms were used in public tweets by individuals. Another very recent example is the one by John Brownstein, who used the Wikipedia click rates on articles related to influenza and to influenza symptoms to estimate again the prevalence of influenza-like illness in the United States. And not only in the United States, but also, for example, in China, where again the team of John Brownstein and Rumi Chunara have used search queries from Baidu to estimate how many individuals from the population were sick in relation to how many times they would look for words related to influenza-like illness symptoms with Baidu. The most famous of these, let's say, digital systems that use proxy data to carry out digital disease detection is HealthMap. HealthMap is a platform funded by John Brownstein. Again, he's your neighbor at Harvard Medical School. And as a first, he suggested that using the news on the web could be a very good idea to carry out outbreak detection. So it's very likely that for some obscure, not yet known disease, is easier to know about it from the news than from official reports that usually lag behind a bit. And so using the news to carry out outbreak detection has been a well-established activity, which is now fully recognized by the epidemiological community. But probably the most famous example for digital disease detection is the one done by the team of Google Flu Trends, which was the philanthropic branch of Google that created this institution called Google.org. And Larry Brilliant and Mark Smolinski suggested several years ago that in 2009 already, that you could use Google search queries as a very accurate proxy to understand what was the circulation of influenza-like illness among the individuals. Google Flu Trends was so successful and relying on such an abundance of data that it became the reference for countries in which the influenza-like illness surveillance was not so well established and working so well. And it became really an example of how in countries where surveillance doesn't work very well, technology can enable the country to do the leapfrog and without going through the traditional well-established surveillance of medical doctor, you can carry out disease detection, digital disease detection in a very efficient and accurate way. Of course, we all know the story. It didn't end well for Google Flu Trends itself, not really because of the data, because the data were, so much abundant that it remains a very powerful source of information, but mostly, say, the modeling part was not well taken care of by Google, who was not actually interested in doing proper modeling. And in fact, now the access to the search query data in relation to flu has been given to the community of modelers, in particular, again, to John Brunson, to carry out proper modeling. The great advantage of systems like Google Flu Trends remain in the fact that they could somehow complement, or I wouldn't say bypass, the traditional surveillance and somehow overcome the limitation that traditional surveillance presented in developing countries. Again, these data are great, they work very well when it comes to a population level, but the problem is that they are based on a passive approach. So we somehow harvest the so-called digital traces that people leave around when they look for the flu on Google, but we really don't know, we really don't have a good idea of he's actually well and he has a disease, so we don't know the so-called denominator. Because of course, when you are feeling perfectly well, you probably won't write on Twitter, today I'm great, I don't have any symptoms, I won't go see a doctor because I feel perfectly fine, while you would do the opposite. Today I feel miserable, I have a runny nose, I have a sore throat. So this kind of approach doesn't help us in establishing the denominator. And also, we don't know exactly what people are talking about when they tweet about the fact that they feel miserable because they have a high fever. Is it influenza-like illness? Is it something else? We don't know. So the specificity of this data is rather low. So to overcome these limitations of the possibilities provided by big data, already in 2008, with Professor Vespignani, we decided to go and ask people, but really, how do you feel? What are your symptoms? Did you have any symptoms? Didn't you have any symptoms? Are you feeling well? So the idea was to really involve the general population in an active data collection focused on their health, with a, let's say, initial study devoted to flu, but with the possibilities offered by this kind of data collection that could be extended to other diseases. And so that's how we started to build a network of web-based platforms for so-called participatory surveillance of influenza-like illness. The idea is to, again, exploit the fact that adults don't go visit a doctor when they're sick, their signal remains undetected, and this is the same all across different countries, regardless the culture, regardless the language. And so we really thought that by starting asking people about to actively participate in this data collection could be a very good way to collect data about influenza-like illness. InfluenzaNet is now a network that comprises basically the whole Western Europe, going from Portugal, Spain, France, Italy, and so on and so forth. I will tell you a bit more how it started, from which country spread to others. And it's based on the fact that these platforms are communicated to the public through communication campaigns, so over radio, TV, websites. And we invite anybody who is resident in a country to register, providing an email address through which we can contact them. And then they receive access to an account in which they can start inserting their data. Their data are somehow collected through a one-time survey that asks questions about, for example, the postal code where they live, their gender, their age, the household composition, whether they have a chronic condition, whether they got vaccination. So really a rich set of information that helps us build a profile for each of our users. And then every week, each user receives a reminder to come back to the platform and fill in what we call a symptom survey. It's actually a survey in which we ask our volunteers, did you have any of these symptoms in the past week? They can answer yes or no, so it's a very good way to have an idea of who is well actually in our cohort. And the symptoms are related to respiratory issues, systemic issues like, for example, fever, joint pain, chills, but also gastrointestinal symptoms. So we try to cover all the possible syndromes that circulate during the season of the flu. They are also asked important questions like, did you visit a doctor for your illness? So we have a very good idea of which part of the population we are observing, whether it is a part of the population visited by doctors or not. Which drugs did you take for your symptoms? Were you absent from school or from work? So also a very good idea of the causes behind absenteeism, for example. And this was established thanks to a science communication project that started in the Netherlands in 2003, the so-called Great Influenza Survey, which is in Dutch is pronounced the Grote Griepmeting. I'm very proud of my Dutch pronunciation. And modelers in Portugal who were in touch with the team in the Netherlands realized very soon that a science communication project about flu, in which you give information on, for example, how a virus can spread, how you should get vaccinated for flu, is also a very good way to collect data. And so Gabriela Gomes in 2005 adopted the platform in order to inform the models for forecasting the flu that she was using at that time. And thanks to the interaction of Alex with Gabriela, we started building the same platform in Italy in 2008. And that's when we realized that it would be good to somehow expand and conquer, let's say, as many European countries as possible. And the system was so flexible. In the end, it was a website with a database that could be localized, could be adapted to the culture of the country we wanted to invade. And so that's how we came to implement the system also in the UK, in Sweden, and then in Spain, France, and so on and so forth, and build what is now the network of InfluenzaNet. Some years after Flu Near You, the American system, inspired, let's say, by the work that InfluenzaNet was doing, started their own system in the US, and in parallel a system called Flu Tracking in Australia was established. So there was somehow a ferment all over the world to try and use the so-called Web 2.0, which is now an old-fashioned concept, to collect data about influenza-like illness. What we have now is a cohort of about 50,000 individuals every year. The participation, as you might see from one country to the other, is rather heterogeneous. We have the Dutch with 15,000 participants. We have Italy with our cohort of about 5,000. But the most important part is that in the past, say, 7 years, we have a very steady cohort that participate every year, and it is enough to get very good information from one year to the other about the circulation of influenza-like illness. Let me mention one of the first successes of this approach. In 2009, we had just deployed the UK platform, Flu Survey, and it was right at that time that the first wave of H1N1 pandemic hit the country. The UK was the only country in Europe who was hit by 2 waves, and we had implemented the system at the very beginning of the pandemic of H1N1, and we were able to compare not only the self-reporting behavior of individuals through our platforms, but also the health-seeking behavior with respect to the Sentinel Doctor system. And what they realized is that during the first wave, everybody was consulting the medical doctors because they were concerned about this new influenza that was circulating, while during the second wave, the consultation rates for the traditional doctors were much lower. So the estimation of the cases of the second wave was really lower with respect to the first. Since the self-reporting didn't change much, we were able to compare these two different behaviors. In terms of participation, again, it's really heterogeneous. So the number of surveys reported by the Dutch cohort is rather higher than in all the other countries. And it's interesting to see that, for example, in some countries like Belgium or even Italy, people tend to come back from one season to the other, while, for example, in the UK, people participate, or even Sweden, people participate for one season and then they don't come back the following year, even though the total number of participants actually increases or remains the same. So this is to give you an idea of how heterogeneous the participation in the various European countries, which are rather diverse, can be. But the incidence data, so the epidemiological data that we get from these countries is rather homogeneous. This is a comparison of the data that we collect through InfluenzaNet with the surveillance data reported by the European Centre for Disease Control. And even if in some cases curves are a bit noisy, overall the comparison between these two systems is rather good. These are curves with a high level of correlation. And the nice thing is that you can compare this kind of incidence from one country to the other because you use the same system, which is something that cannot be said for the traditional surveillance systems. You can have very accurate information about the representativeness of our sample with respect to the general population. For example, we can compare the distribution in terms of gender, in terms of age. You can see that we have, in the majority of the countries, more women than men with respect to the general population. We overrepresent a little bit young adults between 30 and 60 years old. We underrepresent a bit children and elderly people, but this doesn't worry us so much because these age groups are usually very well covered by the traditional surveillance. But this is a very good way to somehow know how we can compensate the kind of information collected by the sentinel doctors. We can have ideas about socioeconomic indicators because we know the average size of family. We can know about the distribution of family composition because we really ask how many adults do you live with, how many children do you live with. So it's also a very good way to know if a person is exposed, for example, to contagious children that go to school or not. We know if our volunteers have chronic conditions, for example, asthma or diabetes. We know whether they smoke or not. In our case, of course, we have a biased sample of people who are more concerned about health, so of course less smokers than in the general population. But mostly important, we know in real time who got the vaccine for flu or not. And this is something very important because in the traditional surveillance systems, you can have a good idea of the vaccine coverage only at the very end of the influenza season, while it's something that we can calculate during the season and also have a very good idea of the effectiveness of the vaccine. This information is important because now the platforms are run for the majority by public health institutions. So in France it's run by INSERM, in the UK it's Public Health England, in Denmark it's the Statens Serum Institute, and so on and so forth. And so for them it's really crucial to know in real time how many people got the vaccine for flu and whether the vaccine is working or not. Thanks to this very accurate information, we can also have a very good idea of what are the risk factors for being infected with influenza-like illness. And for example, unsurprisingly, if, for example, a person smokes or lives with children or is exposed to groups of children, has a higher probability of getting ILI, while, for example, using public transport is not a risk factor. factor. So you would think that using your own car protects you from getting influenza-like illness, while according to our data, that's not the case. So using public transport is not a risk factor. You can use these platforms for many other studies. For example, the French team is carrying out a study on pregnant women and on their attitude towards vaccination in general, not only for flu. Very recently, we published a paper on a pilot study on the possibility of engaging volunteers for self-swabbing and couple the syndromic surveillance with serological confirmation. This is only a pilot study, but we hope to somehow extend these to other platforms. So I hope I gave you the idea of how these platforms can be really flexible, can be used not only for influenza-like illness, not only for diseases, but any kind of behavioral and more, let's say, social study. But we were talking about forecasting. So we mentioned the fact that we want to use digital traces to carry out forecasting. The examples that we have seen through Twitter or Wikipedia are carrying out what we call mainly nowcasting. So using, let's say, real-time data to have an idea of what's going to happen next week or in the next weeks in terms of flu incidence. But what we really want to do is what is done when a tornado or a hurricane hits a country. You really want to be able to predict a bit more in detail the trajectory of the system, and also be able to really have a longer time frame in terms of what's going to happen. And this is something that so-called big data are somewhat limited because of the issues that I mentioned, denominator, specificity, and so on and so forth. And that's why we try to use and try and see whether these accurate data that we get from the general population can help us in carry out disease forecasts. So we started from the worst possible case. Italy, as I mentioned, has a rather I would say limited number of active users. We are 60 million in Italy, so a sample of about 1,000 of active users per week doesn't seem so big. But as I showed you, it's a very good way to have a good incidence curve. But we can do more. We have tried and built a model in which we integrate the data from the sentinel doctors and from InfluWeb, so from the web-based surveillance, to try and build a model with an exogenous, let's say, part, through which we try to forecast the flu with a time frame of at least 4 weeks. And consider that this is a very simple model that is using data from sentinel doctors and from a sample that in the end is not so large. But the results are pretty encouraging because in the end, with a time frame of 1 week, 2 weeks, or 0 is the baseline model, that is the model used to make predictions based only on sentinel doctors' data. And 1 and 2 and 3 are models in which we add terms that keep into account data from 1 week, 2 weeks, or 3 weeks retrospectively from the InfluWeb platform. And we can see that the forecasting is rather accurate, even when we go to 4 weeks prediction, which is the ARCS-4W model, so that we have let's say, a pretty good confidence that if we use this model to forecast what's going to happen in terms of flu incidence in the next 4 weeks, we can be confident that the data that we get are rather informative. These are some, let's say, metrics that we used to estimate the goodness of the models. So not only in terms of timing, but also in terms of height of the peak. And the performances, as you might see, are rather good, especially for the k equal to 3. It's a good percentage in terms of how good we get the estimate in terms of number of cases.
Compared to?
Compared to the baseline model, that is the model for which you would use only sentinel doctors surveillance.
So it's the doctors report.
Exactly. So this is a very simple model in which we just do autoregressions based on the data that we have. But of course, we can do much more. And I really don't need to introduce this model has been developed in this very institution since many years. But the important part is that this rich data-driven model that Alex Espignani has been developing for the past decade is built on several layers of data, which give a very accurate representation of the distribution of the population, and also a very accurate representation of the network of mobility, both short range and longer range, by using air travel. So, as you know better than me, this data-driven layer of approaches is coupled to a compartmental model, which is rather flexible and can somehow adapted to several diseases, which then can be used to do epidemic forecasts on a global scale by using this kind of computational framework. So this has been successfully used in an endless number of situations, ranging from the H1N1 pandemic to the more recent epidemics of Ebola and Zika. But the crucial point when it comes to seasonal influenza is that how do you initialize your simulations? Because in order to provide the initial conditions for which then you can generate your models, you really need to know the very first cases, when they happened and where they happened. And when it comes to pandemic, of course, the alert is very high, and so you know exactly when the first imported case of H1N1 arrived in Spain, for example, and use that as an information to initialize the simulations. But when it comes to seasonal influenza, of course, it's some kind of information that we don't know. But then we have our volunteers. We start the data collection with our volunteers more or less around mid-October, when usually the epidemic of seasonal influenza is not yet started. And so we know that by the time the epidemic will start, our data collection system will be already in place. And so the very first cases we will start seeing of self-reported influenza-like illness might be good candidates to inform these systems. And this is exactly what we did. We somehow integrated the surveillance data of InfluenzaNet to estimate the initial number of infections in the various regions of the European countries that we were studying. And then we used the framework of GLIM to carry out the work that you know very well in terms of predictions and estimation of the timing and severity, let's say, of the peak for seasonal influenza. We did it for several countries. The procedure is what you again know better than me, is to use the initial conditions provided by InfluenzaNet to generate a series of epidemic scenarios, which are then somehow constrained by the incoming data of traditional surveillance. So the idea is that you use InfluenzaNet to generate a plethora of scenarios, and then week by week the simulations are somehow adjusted and chosen based on the data that the traditional surveillance of medical doctors provide, so that during the whole seasonal influenza period, we have a tool that will provide us with a series of scenarios that get better and better as more data come in, but that rely on really realistic initializations of actual flu cases from the general population. We tested this framework in several countries, so UK, Spain, the Netherlands, Italy, Denmark, Belgium. The results are mixed in the sense that, for example, in Italy, as you can see from the various, let's say, 4 weeks in advance, 3 weeks in advance, and so on and so forth, the signal gets much better. Because in this particular case, the season was a rather, let's say, normal one. In countries in which the season was a bit noisier and and with the lower incidence, like for example in Belgium in the first row, then predictions were harder to get a good estimate early, but then we had a very good idea of what the unfolding of the epidemic will be. This has been somehow packaged to be disseminated to the general population, but also to the scientific community through a platform that it's called throughoutlook.org, that thanks to the hard work also of people like Chan, Anna, and also people at ISI, have been informed with data and the possibility of navigating in an interactive way the results of the simulations week by week for different countries. We could even compare the results produced by the forecast generated by GLIM with other, for example, autoregressive model such as those we have seen at the very beginning. So this is a very good way to show how these kind of models can be used in several countries, very diverse in terms of circulation of the flu, but with a uniform data collection and with a uniform modeling tool, the results can be pretty useful. This has been also provided for the public health institutions that are involved in InfluenzaNet, and is considered a very informative tool for them in order to somehow plan in advance the interventions that are going to be put in place at the beginning of the influenza season. Until now, I will close with a part that is still a work in progress, but I would like to share with you. Until now, we have somehow put under the carpet the fact that when it comes to influenza-like illness, even defining what it is rather messy. Traditional surveillance is based on symptoms reported by patients who are seen by a doctor. Our surveillance is based on symptoms reported by volunteers over the web. But then how do we aggregate these symptoms and say, okay, this is a case of influenza-like illness? Well, as you might imagine, there is a lot of variety, a lot of arbitrary, let's say, decisions, especially on the public health side. And this is, for example, the European Center for Disease Control case definition, which has decided that if your symptoms started sudden, if you had at least one of 4 systemic symptoms related to fever, malaise, headache, or myalgia, and at least one of 4 respiratory symptoms, then we decide that you have influenza-like illness. But this definition is far from being adopted by all the public health institutions in Europe, for example. The CDC definition is different. In France, until 3 years ago, they didn't even use ILI, they would use ARI, acute respiratory infection definition, so really another set of symptoms. So how do you somehow put together all these different information? What we have been doing until now is, okay, you called this influenza-like illness, I don't care which kind of definition you used, we try to forget the fact that it's slightly different. But what we try to do is, okay, we collect raw data, we collect directly symptoms from the population. What if we use these symptoms to try and come up with a more, let's say, realistic definition of what influenza-like illness actually is? And also, what is the perception of influenza-like illness among the population? Because these are the symptoms that are self-reported by the volunteers, so even the cognitive aspects are important to be taken into account. And even if a person might have several symptoms, those that they report are those that they consider most relevant for their health, so you might want to know which kind of symptoms you are collecting. So what we did was, what if the symptoms that we observe, self-reported by the volunteers, are actually the superposition of syndromes that we really don't know in detail among the general population? Syndromes are really manifestation of a specific disease, and syndromic surveillance means that you do surveillance based on the symptoms that you observe, but you don't really do the virological confirmation or the serological confirmation. So, since influenza-like illness is based on syndromes and on syndromic surveillance, we postulate that what we observe is the result of syndromes that circulate among the population and for which we don't want to give a priori definition like instead traditional surveillance is doing with influenza-like illness. So I won't go too much into details for sake of time and leave some time for questions, but what we did was to somehow transform the data that we collect about symptoms daily in a matrix in which we have in each element the number of times that specific symptom has been reported by the population. So, for example, 125 times fever in 28th of March, and I don't know, all the counts for each specific symptom aggregated on the data that we collect from our volunteers on the 11 countries. And then we expressed this matrix of daily counts of symptoms in a way that we assume that the matrix is somehow the superpositions of these time series of these signals that are regulated by unknown coefficients that we want to find with a noise term. So what in the end we can somehow do is to formulate our problem as a matrix decomposition problem. So what we know is the matrix X, which is the number of counts of symptoms each day, and we really want to understand what are the signals and what are the weights of these signals that mixed together produce the matrix that we observe. We used the usual approach of non-negative matrix factorization with a twist that has been used in semantic analysis of text corpora that provides a probabilistic interpretation. If you want to know more details, we can discuss it separately, but what I would like you to focus on is the fact that in the end, the total number of counts that we observe for each symptom each day is the result of components that we want to determine. The K is the number of the components combined together that give result to the counts that we observe. And in the end, the game is really determining these components K that produces the signal that we observe and which symptoms contribute more to these components. The data that we have used for this study are data from basically all the countries that we have. We have an average of 200,000 surveys per season in the Netherlands to a smaller number of surveys. But put together, all these data provide a very nice data set of symptoms counts for several seasons. We have used seven seasons of data. The result, and then I won't go too much into the details, is that then for each country we have a set of time series of components that combine together give way to the signal that we observe in terms of symptoms counts. They are 3, for example, in the Netherlands, they are 3 for Belgium, they are 4 for France, only 2 for Italy. These components have been selected by the model, by the algorithm, and the green square, I will tell you in a moment what it is, but it's interesting to see that in the majority of the countries, 2 or 3 components is what we found. And then the green square is the component that better correlates with the signal of influenza-like illness generated by sentinel doctors. So for each of the components generated by the model for each country, we selected the component that is the time series that better correlates with influenza-like illness of the sentinel doctors, so that we could somehow have the best time series that reproduces what the sentinel doctors observe. And for each component, we have the composition in terms of contribution of the single symptoms. And so, for this component selected, for example, for the Netherlands, which better correlates with the influenza-like illness of the sentinel doctors, which then we can assume is the signal that better reproduces the actual circulation of influenza-like illness, those are the symptoms that more or less contribute to the signal. So we can see, for example, that in the majority of the components, fever and chills, I don't know if you can read those symptoms there, are the main contribution in terms of weights. Sudden onset is the last one, is also very high in all the components except probably France. So this is a very good way to discriminate which symptoms actually contribute more in each signal. And as you might see, the situation is not the same in all the countries. So it's probably not a good idea to use the same definition in all the countries, and also probably season by season. These are time series that are used for 6 years of influenza, but then you can use this data to predict use these weights to predict the signal for the next year, and use your own data-driven definition of influenza-like illness. I will skip these. The next step for this approach is, of course, using virologically confirmed data to have a better, let's say, a better data set to which compare the results. We want to use this model for other countries and for other syndromes. We can do the same, for example, for gastrointestinal syndrome. So as long as you have surveillance data to which you can refer for the validation, you can use this algorithm for many other diseases. And also use it for example, the detection of emerging diseases. This is somehow the conclusion of the overview of what we can do with this data. I would like just to mention the fact that we flew near you, the American system, and flu tracking, the Australian system. We are now finalizing a partnership that started several years ago, but we are now coming to the moment in which we are going to share all the data to build really a global sensor for influenza-like illness on the northern and southern hemisphere. And we really plan to implement this system in other countries in which the surveillance is not so well established, like for example in African countries, but even South American countries in which traditional systems don't provide such good data. In terms of more general, what's next for InfluenzaNet? Well, for example, we used the platform in Italy to track imported cases of Zika. During the summer, we left the data collection open so that in case we would observe unusual influenza-like illness activity, we could carry out follow-up questions to ask whether people traveled or not and advise them to look for medical assistance. Again, participatory surveillance in developing countries is something that we really would like to do. Other health-related issues I already mentioned. And last but not least, validation of passive web data. So the data sources that we mentioned at the very beginning, Twitter, Wikipedia, we could somehow link the finding from those data with the finding from these data to somehow validate the approach of the so-called big data. And I'm very happy to mention the fact that exactly yesterday there was this article, this Outlook article, Infection Forecast Powered by Big Data, in which InfluenzaNet and FluNearU have been mentioned as very important sources for real-time digital disease detection for infectious disease. Let me thank all the people involved in InfluenzaNet, which, as you might imagine, are many. InfluenzaNet has been developed in the scope of a European project called EpiWork already 10 years ago. And also many thanks to the people here at MOPS Lab who are great, provide a great collaboration, who are really our reference when it comes to forecasting. And with this, I will accept your questions.
I'll start it off. So, how many latent syndromes did you give to NMF, or was it model selection?
It was model selection. Yeah, I didn't mention the fact that in the end the selection is done through the ACAIC criterion, so it's semi-unsupervised.
I see.
We let the model be selected by the criterion, and so we get a number of components that is not a priori established by us. It's selected.
And how many components does it usually pick? Or?
So it's usually, as you have seen, 2 or 3 for each country. For France, there were 4, for example, because they use slightly different data in definition, so their variety is larger, but usually it's 2 or 3 components, among which we pick the one that is the best correlation with Daniela. Other questions? Yes, Misha.
Excellent talk, thank you. I particularly like the fact that you trying to go into deeper modeling. In fact, your example with weather, right, is a very nice one because that's a combination of really purely data-driven, but also mechanistic models. So they include the differential equation that describe the evolution. And I was wondering to what extent you think that it would be possible to go more mechanistic here, because if we could, right, we could influence or at least understand how behaviors, like washing hands or whatever, influence spreading, and why is influenza so a season? Why is it seasonal, right? Why does it occur in the winter, or these months, at least in northern hemisphere? So I was wondering if you have some plan to go in that direction, because that would be actually actionable.
Yeah, exactly. So the good thing of having a cohort of volunteers is that you can actually first ask more questions if they let you, but also really observe longitudinally what happens in the same cohort from one year to the other. We have started some studies on vaccine, not only effectiveness, but mostly attitude. We have seen in the past years a decrease in the vaccination uptake in several countries, so we are trying to understand a bit more why that's the case. But that's really one of the few aspects that we are studying. For example, intervention measures related to hand washing are also something we would like to try. And also all the possible, let's say, behavioral nudging is of interest. For example, people who live with children are on our radar, because it would be interesting to understand whether, let's say, the caretaking of children affects, as we have seen, it does, of course, the probability of getting the flu. So, but for this we need to, let's say, enlarge the cohort. For the moment, we have a very good way to get good epidemiological data, but in order to carry out behavioral studies, we need to enlarge the course, and that's also what we plan to do in the next years.
So that was a really good question, because I wonder, in your surveys, do you ask them what they were doing 24 hours before they started having the symptoms?
Well, we ask when the symptoms started.
Right.
We don't ask exactly what they were doing before that, because we have noticed a difficulty in recalling precise information. It's already a lot that they remember the date when the symptoms started, so that's already very good information, for example, for the simulations. But also knowing a bit more about their health, their lifestyle is already a lot. So we know whether they smoke, whether they use a bike, the kind of diet that they have, whether they assume drugs for their illness. So all this information are already very good picture of what's their risk of getting ILI. But in some countries, we are trying to do more in-depth studies on specific aspects, for example, vaccine, nutrition, and so on and so forth. Basically, the possibilities are really endless. It's just that you don't have to burden your volunteers too much with questions, otherwise you will lose participants. So these systems, of course, I didn't mention, but the elephant in the room is to attract volunteers and to keep them engaged. And that's the hardest part. So we have to strike a subtle balance between the amount of information that we can extract for them and not to bother them too much, otherwise we lose participation. But
oh, I think he was first. Sorry.
I'm interested in thanks for your great talks. And yeah, I am interested in the data part where you mentioned the networks for population symptoms. So by doing the non-negative matrix factorization, you sort of say extracting communities of symptoms that would already.
Yeah.
Are you interested in that aspect or not really? For example, if you say, I mean, well, my question is admittedly vague, but the components seem to be very consistent across countries. So. And then the different symptoms may belong to the same group, which are sort of say connected to each other. Do you have any thought about this sort of
Yeah,
thing?
this is something that we are planning to do in the second step. So this was really a way to see if this data could tell us a bit more about the definition that would emerge from the data. But then the second step will really be, okay, let's see exactly which symptoms are in each component, and if we can come up with some kind of co-occurrence of symptoms, for example, or a definition that emerges from the data that can be applied in as many countries as possible. So, an unsupervised definition of influence factors in the end is the goal.
Great talk. I was wondering about whether you could use some of the same ideas to look for differences in reporting behavior over time. So, like whether the definition, whether the components change over the course of the flu season, like maybe they get more relaxed or...
Yeah, this is very interesting. Also because, as I said, these all self-reports is tied to the perception that people have of their own symptoms. And it's something that we haven't tried yet. We just put all the data together, but probably seeing the different emerging components according to the, for example, number of surveys that are reported at each step of the season is something that we are doing in collaboration with Nicola Perra. We are trying to understand what is the perception of the epidemic with respect to the actual circulation of influenza. So we are asking our volunteers what is their perception of seriousness, let's say, of the epidemic before the peak, during the peak, and after, and longer time after the peak. So we will have an idea of their self-perception. We will have the kind of symptoms that they reported during these specific times, and we will probably be able to see whether there is a variation in the kind of definition that we can observe. Yes, that's a great question.
I have one last question. So obviously you have to deal with selection bias, right, whoever it is. So in your surveys, for example, do you have like a text box which is optional, which I can go in and type stuff?
No.
No.
For that, we try to avoid the free text fields because they are completely unusable. But of course,
what do you mean they're unusable?
we are epidemiologists. We really want to count cases, and this is not happening. But we already have we try to collect structured data. Eventually, we will go in that direction, but for the moment, we try to stay away from that.
Right.
But in terms of selection bias, of course, as you might imagine, we have all the self-selection problems, like highly educated people who have access to a computer, who mainly live in cities, who are young adults. The system allows the data collection for children, for example, so you can create a household and insert data for your children or for your parents that really don't want to use a computer. So we try to correct with that. And also the let's say, perception bias. So when I am sick, I am more prone to report. So this is also a bias for which I correct. But these are all biases that we can control for. So it's something that we can correct. And again, it's a bias signal, but it's complementary to the sentinel doctor. So we know that it's somehow a piece of information that they wouldn't have anyway from a part of the population that is not representative, but it's unknown to the sentinel doctor, so it's a piece of information.
Because I was thinking if you provide a text field, I'm going to make one more push for the text field, then you can maybe separate out the hypochondriacs from the non-hypochondriacs.
Actually, we tried. We had a free text box in which what do you think is causing your symptoms? But we had all sorts of really crazy inputs. And in the end, we were like, what do you think is causing your symptoms? Influenza, something else, cold, or
I see.
Really limited to the possibilities.
Right. I'm not speaking from experience. I'm just saying.
But that's super interesting. We will give it another try.
Another try. Okay. Any last questions for Daniela? No. If not, let's thank her for a great talk. Thank you so much.